皆様、本日は人道援助コングレス東京2020にご参加いただき、誠にありがとうございます。現在、世界では難民、国内避難民の数は増加し、紛争は長期化の傾向が見られます。シリアやイエメンをはじめとする国々で紛争が続き、数千万もの人々が長期にわたる避難生活を余儀なくされています。さらには気候変動による影響や、エボラ出血熱、新型コロナウイルスなど感染症の流行も深刻です。今般の新型コロナウイルスの世界的な流行によって、医療へのアクセスはこれまで以上に大きな問題となり、社会的に弱い立場にある人ほどその影響を深刻に受けています。新型コロナウイルスの対応に多くの資金、人員が投入される一方で、これまで供給されていた基本的な医療サービスが移動制限や資金、人員不足によって大きな打撃を受けていることも事実です。また、保健医療セクターだけでなく、食料や教育といった人々にとって不可欠な分野でも同様に新型コロナウイルス流行によるさまざまな影響を受けています。このようにさまざまな問題が複雑に絡み合う中で、人道危機はこれまでと変わらず発生しており、それに対応すべき人道援助のニーズも多様化し、それに関わる我々の対応も複雑にならざるを得ません。一方、世界では自国第一主義の台頭が顕著で、対テロ政策、国境封鎖による難民受け入れの停滞などから、人道援助の実施がますます困難になってきています。紛争や暴力を逃れ、国境を越えて避難する人々が十分な保護や援助を受けられず、また地中海を渡る移民・難民が人命救助すら受け入れられず命を落とすような現状が何年も続いています。ここには人々を救う援助活動が政府の規制によって実施が妨げられるという事態も起こっています。また紛争地では反政府エリアにおいて住民に援助を届けることが反政府的な犯罪行為とみなされ、援助を必要とする人々にアクセスすることができないという状況も生まれています。国境なき医師団の緊急人道医療援助活動は、独立、中立、公平の3原則にのっとり実施されています。援助団体が人道援助を提供することができる人道スペースの確保が、世界のさまざまな地域で難しくなる中、今、改めて人道援助の原則に基づいた援助の意義、必要性をこの人道援助コングレスにおいて皆様と共に考えていければと思います。国境なき医師団は今までベルリン、ウィーンにおいて人道援助コングレスを他団体と共に開催しており、日本においても人道援助をめぐる諸問題を共に考える場を作りたいと考え、人道援助コングレス東京を立ち上げることといたしました。東京で初めての開催となる今年の人道援助コングレスでは、コロナ禍における人道援助とその課題をテーマとし、3つのトピックについて議論を行います。ご登壇くださる有識者の皆様とご参加くださる皆様の活発な質疑応答を期待するとともに、人道援助コングレスがご参加くださった皆様にとって有意義なものとなりますことを記念し、開会の挨拶とさせていただきます。ご清聴ありがとうございました。
Good morning, good afternoon, and good evening to all the participants. Welcome to the first session of the Humanitarian Congress Tokyo 2020. My name is Shuichi Furuya. I'm here as a moderator of this session. I'm a professor of international law specializing in international humanitarian law, which is applicable to the situation of armed conflict. But I'm not so familiar with the actual activities of medical care and humanitarian aid in the field of armed conflict and the challenges medical and aid workers are actually facing there. So I'm also very looking forward to hearing the
いらっしゃるのか、それを今日は
and online discussions between them and the audience. So Before introducing three speakers, please allow me to explain the general background of this session's topic, attacks on medical care. Many people remember that the
はじめ
MSF
進めさせていただきたいと思います。
in Kunduz, Afghanistan, was attacked by the US Air Force in 2015. Next year, 2016, the United Nations Security Council passed a resolution 2286, which called for ensuring the safety of medical humanitarian aid workers. However, attacks on medical facilities have never ceased. Even after the resolution was adopted, we have witnessed so many attacks taking place in countries such as Afghanistan, Syria, Yemen, and so on. According to the report released in 2019, last year, by the Safeguarding Health in Conflict, of which chair is Professor Reuben Stein, one of today's speakers, there were at least 1,203 attacks on health workers, health facilities, and health transportations in 20 countries in armed conflict around the world. And at least 151 health workers were dead, and at least 502 were injured as a result of these attacks. We also have to pay attention to the fact attacks on medical facilities and personnel have been reported during responses to Ebola and COVID-19 outbreaks. ICRC reported this August that more than 600 incidents of violation and harassment against healthcare workers, patients, and medical infrastructure in relation to COVID-19 have been recorded only during 6 months from February to July of this year. These incidents were across more than 40 countries, and more than 20% of them involved physical assaults. Under international human rights law, all the parties to armed conflict are obliged to distinguish combatant participating in hostilities and civilians who are out of military activities, and particularly the medical personnel and the facilities indicating the emblem of Red Cross, Red Crescent, or Red Crystal should be protected and not to be a target of any military operations. However, as I mentioned, there have been a huge number of violations of international humanitarian law, and for providing humanitarian aid effectively to people in need, the protection of medical personnel and the facility is a very, very crucial issue we should tackle with seriously. In this session, we are going to share the information about attacks on medical care and discuss the actions required to address this issue. I hope this session could be a valuable opportunity for all the participants to increase awareness of this issue and join us in taking actions to improve the situation. So this ends my brief comments on the topic we will discuss today. Now I would like to introduce three distinguished speakers we invited to this session. So first speaker is Mr. Maciej Polkowski. Mr. Polkowski is the head of Healthcare in Danger initiative with the ICRC in Geneva since January 2018. Prior to this position, he worked on the protection of healthcare with the ICRC in the field and developed a multidisciplinary approach based on partnership across the health sector, academic research, preventive legislation, and media campaigns. He has worked for the ICRC in various positions in South Asia since 2005. He is joining us today from Geneva. Mr. Polkowski, thank you very much for joining us today. Thank you. And the second speaker is Mr. Sinjiro Murata. Mr. Murata is the General Director of MSF Japan since last August. He was the first Japanese head of the mission in MSF, responsible for projects in countries including Syria, South Sudan, and Yemen. He has spent more than 10 years in the field. This year, he graduated from the master program of Herbert Kennedy School as a John F. Kennedy Fellow, where he developed advocacy strategies to reduce attacks on healthcare in conflict zone in order to restore and maintain access to healthcare for people in need. The last and the third speaker is Professor Leonard Rubenstein. Professor Rubenstein is the chair of Safeguarding Health in Conflict Coalition. He has written extensively on the problem of violation against healthcare in armed conflict and founded the Safeguarding Health in Conflict Coalition. He is a professor of the practice in the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health and director of program in human rights, health, and conflict. He is the author of forthcoming book, Perilous Medicine, The Struggle to Protect Healthcare from Violation of War, to be published in 2021, next year. He is joining us from the United States, and for him, it is a very, very early morning now. So thank you, Professor Rubenstein, for your kind acceptance to be a speaker in such a large difference of time zone. Thank you very much. So I'm sorry I took a little bit long time for my introduction, but now I would like to invite speakers for their presentation. I'm going to give a floor to the first speaker, so Mr. Polkowski, you have the floor.
Thank you so much for this kind introduction, Professor Furuya. It's an honor for me to participate in this Congress and to speak on such an important humanitarian issue. Please bear with me as I pull up my slides. Hopefully they should be visible to you and everybody by now. Thank you again for this opportunity. During my brief presentation, I'll try to speak about the history of protection of the medical mission, and I'll also provide the ICRC perspective on the issue with a particular stress on practical, concrete solutions that can be deployed in the field in order to advance this cause. For us in the Red Cross and Red Crescent movement, this is an issue that's really at the core of our mandate, and you could even say that it's a foundational issue for the ICRC and for the Red Cross and Red Crescent movement as a whole, because when Henri Dunant first thought of creating this movement and of creating an international legal framework on humanitarian issues, what it was about was mainly about protecting the wounded and the sick and those who provide them with life-saving care. This is how the emblem and the Geneva Conventions came into being, really. Unfortunately, more than a century and a half after these lofty ideas were put down on paper and accepted by states, we continue to see violations in conflicts across the world. The last decade has provided multiple examples of quite shocking and flagrant violations of the international humanitarian law, especially in a number of countries in the Middle East and Northern Africa, for instance, where in certain cases more than half of medical facilities were severely damaged or completely destroyed. But it's not just about hospital bombings, it's also about obstruction of ambulances and obstruction of access to difficult to reach populations. And it's not only about attacks that are carried out willfully as part of a military strategy. It's also about general insecurity as a factor preventing access to healthcare for large portions of populations. And I think this is especially true in the case of preventive care. Such problems don't only affect countries in war, but are also present where there's high levels of criminality. Moreover, there's issues having to do with militaries and law enforcement actors, as well as non-state armed groups not being able to behave appropriately towards healthcare, including in situations where they are called upon in order to protect facilities or healthcare activities that are being deployed. What's even more worrying than that is that violence against healthcare is not only carried out by belligerents, weapon bearers, but that more and more often it comes from the civilian population itself. Paradoxical situation where the people who are in need of the care are the ones that prevent it from being deployed. And that's a problem that affects not only countries in conflict again, but also some highly industrialized and developed societies. In terms of COVID-19, we have seen that it has had an impact on the patterns of violence against healthcare the world over. It has exacerbated existing and endemic violence that can be encountered in healthcare settings universally, but it's also triggered some new specific types of violence, such as, for example, when healthcare providers are unable to hand over dead bodies to families. This has, and that meets with lack of understanding. We have seen such situations in multiple countries. There's also an atmosphere of what some people have called global moral panic, driven by fear associated with the pandemic, that has led sometimes entire communities to ostracize, shun health workers, health facilities, expel people sick from their neighborhoods. And once again, this is something that is a global phenomenon that touches very different countries and very different societies. Another distinct pattern that we have observed is that healthcare workers faced with unprecedented pressures and difficult working conditions while responding to COVID have voiced their protest against what they see as insufficient support by the authorities. And sadly, this has often been met with a disproportionate response. While on one hand, based on the public health imperative, authorities have the right to requisition the services of healthcare personnel and to direct them to specific duty stations, for example. On the other hand, this happens in the context where sometimes there had been underinvestment in the security and safety of those healthcare workers during the preceding years. While it may be easy to become disheartened seeing these continuing violations and violence, we believe that there are multiple things that can be done, very practically speaking, in order to counter these trends. And what we call the healthcare in danger theory of change, and what forms the cornerstone of the ICRC strategy on protection of healthcare, establishes a dual general goal, which is to reduce the prevalence of such incidents, but also to mitigate their consequences. And it speaks of 4 specific things that need to happen in order for that to be possible. So first, weapon bearers need to increase their respect towards healthcare. Secondly, states need to bring in better legislation, more comprehensively covering protection of healthcare, in line with the exigencies of the international legal frameworks, but sometimes also going beyond them. Thirdly, healthcare providers also need to be aware of their rights and responsibilities, and they need to be practically prepared to cope with such situations. And fourthly, we need to speak to the general public through the media primarily, in order not only to counter the trend of violence by the civilian populations, but also to use the general public to hold weapon bearers and decision makers accountable. Contributing to all of this is the ambition to mobilize relevant stakeholders around these issues and to generate better evidence, because that is so far not sufficient. This may seem to you as relatively abstract ideas, but to illustrate them, I wanted to bring in a few practical examples from the field. And I will start with a case from Lebanon, where working in a Palestinian refugee camp containing 100,000 people in the space of 1 square kilometer, so a very dense urban environment. We worked over several years with the local communities and with the local armed groups, and there's several of those active within that limited space, to develop unilateral declarations of respect for healthcare that were then signed by those armed groups in a public ceremony. We are now working with the community to hold them accountable, and we have reasons to believe that this initiative has already brought positive outcomes, especially for the only hospital that offers emergency care within that community. Secondly, El Salvador provides an example of work on domestic legislation, where since 2016 we collaborated with the Salvadorian Red Cross, with the Ministry of Health, with a number of ambulance service providers and other health stakeholders to create an interinstitutional coordination protocol with the idea of preventing violence against healthcare at its center. El Salvador is a country that experiences high levels of armed violence that have historically severely impacted the provision of life-saving medical care. Earlier this year, this protocol was voted into law. It is an example of how legal solutions can and should go beyond the mere suppression of violations or harmful acts, and should also take into account the regulation of the healthcare sector, interinstitutional collaboration, coordination, and so on and so forth. Thirdly, in terms of a practical example of preparedness of healthcare workers, the work carried out by our colleagues and the management of the emergency department in the largest hospital in the northwest of Pakistan provides an interesting insight, I believe, into what this can look like. What you see on the screen is a graph that demonstrates the increased number of weapons that were seized at the entry into the hospital. Over several months, we worked with the hospital administration, with its security guards. We installed metal detector gates, developed standard operating procedures, and so on and so forth. At the end, resulting in improving the capacity of the hospital to prevent the entry of weapons onto its grounds. Previously, especially in the context of mass casualties, that was a significant problem, resulting in fear and incidents in this large hospital serving a key population. As an example of a media campaign aimed at fostering general respect for healthcare by the population, here's our work from Iraq, where we worked with the Ministry of Health, with the Iraqi Red Crescent, as well as a number of civil society stakeholders and private media channels, in order to run a series of campaigns. Iraq, in its post-conflict scenario, has unfortunately seen a lot of violence against healthcare by tribal groups, civilians, and so on and so forth, crippling the system. As I said before, for all of that to be effective, we need to work together. And while previously there was a lot of focus on work at the global level, which resulted, amongst others, in the insertion of IHL compliant language into a number of resolutions at the World Health Assembly, General Assembly, and the Security Council. We now see collaboration at the national and subnational level as a priority, and we always aim to collaborate with national nursing councils, national medical associations, and so on and so forth. We also continue to work for better evidence base, and we recently published a global overview covering existing research in 5 languages on this topic, with the aim of creating a funding stream together with our partners that will support actors in conflict affected countries to design better evidence-based strategies to protect healthcare. I hope this has provided you with a bit of an insight into how we try to practically address this topic. Thank you very much for this opportunity. I look forward to hearing the other presentations and to answering any questions during the discussion. Thank you so much.
So thank you, Mr. Polkowski, for your very, very insightful discussion concerning this issue. Now I would like to invite the second speaker, Mr. Murata. So Murata-san, I think you are ready. So I think, okay, so you have the floor, Mr. Murata.
Thank you very much for the introduction, Professor Furuya.
古谷先生、ありがとうございます。
Mr. Polkowski, ICRC. From my side, I would make a presentation about the attacks on medical care from perspective of MSF Japan. I hope now my screen has been shared. And excuse me. So as I mentioned,
先ほども申し上げましたけれども、プレセッションの方で、今日のご紹介いただきましたけれども、基本的には3つのこのセキュリティマネジメントの戦略というものがあります。人道援助の組織として、この紛争地域で活動していくためには、MSF でどのような活動をしているかという話と、また我々の方の分析ですね、そしてこの現在のこの傾向に関する仮説について話をしていきたいと思います。どうやった形でこの課題に対応していくのかについて触れていきたいと思います。現場の方では、ここにありますように、3つのこのセキュリティの管理の戦略があります。まずは受け入れということなんですが、理解を得て、そしてさまざまなこのローカルの当事者からサポートをいただいていくということですね。私たちの活動に対して、次が保護ということなんですが、これはセキュリティの対策の上でも最小限の部分ということになりますが、例えば窃盗であったりとか、それをから保護していくということですね。そして阻止。これに関しましては、こういった武装行為というものを阻止していく、私たちに対する行為を阻止していくと、武器を備え、武装をしてということなんですが、この受け入れの戦略というものがとても重要かというふうに思いますし、私たちに関連しているかと思います。この阻止のデテランスの戦略を実施していきますと、やはり我々としては、この人道援助、医療組織ということなので、
And also, even if we have lots of, we are totally armed, it doesn't mean we are always protected. Unless we have an acceptance, good acceptance, understanding, the support from different actors in field, even with lots of weapons, there's no security. So that's why we think the acceptance strategy is the most important. Then here I already mentioned in the previous session, so I do it quickly. So we have these different local actors, and of course in official side also, and we have our staff and other organizations. So as you can see, there are lots of different actors with different political agenda and different tribal or community agendas. For us, for instance, whenever I was in field, what I said is, look, MSF, we don't have interest in politics, to be involved in politics. What we have interest is to understand the medical humanitarian needs among your communities to provide our assistance to people in need. And the word is easy, but it's not enough, because in some contexts they are fighting each other in some conflicts and war situations. So we need to have a kind of strategy to gain acceptance from these actors. And in our opinion, there are in total 5 points to consider. First, it's important to maintain humanitarian principles. It's independent, neutral, and impartial. Independence from political powers, to keep neutrality in the name of medical ethics, and to keep impartiality from the points of view of the people's rights to access to medical care. We need to maintain these principles anytime, anywhere, for anybody. And also it's important that for influential actors, it's important to keep transparency of our activities. What we did in the last month, what we are going to do in this month, and what we are going to do in the next coming 6 months. So that's to avoid creating any suspicions. But until here, if we do only here, it means we are just like a harmless organization. But it's not enough. To work in conflict situations, to gain acceptance, we need to show our added value to the local communities. It means, as a medical organization, we need to provide quality medical care to communities on daily basis. Without quality, it can spread a bad rumor that hospital is killing people and etc. So that's not good, not only from medical point of view, but also for our security point of view. And then in case of an emergency, it's the moment when the people need medical humanitarian assistance the most. So for us, as long as our security situation allows, we want to stay there to maintain proximity with people, but also to provide medical intervention. And then lastly, it is important to show our respect toward their local culture, tradition, and religion. Because in the end, even if we provide quality medical care for free, we are outsiders. So unless we show our respect to these important their culture, tradition, and religion, in some context, it can create a security threat very easily. As long as we maintain these 5 points, except for some very exceptional cases, basically we can work. We can reduce the security risk. It's impossible to reduce it into zero, but we can reduce security risk by having these measures, basically. So do the context analysis. Based on analysis, we do security risk analysis, and we decide which kind of security rule we have. We implement.
What
I wanted to say here is to do good context analysis, you need to have a good networking with various actors in field, and to gain acceptance from to establish network with these actors, it's important to implement such acceptance strategy. So that's how we work MSF as MSF. But as we mentioned in the beginning of the pre-session, we have several challenges, and which is one of them is in the theme of this session, attacks on medical care. For instance, in Afghanistan, we had a big incident in Kunduz, in the northeast of Afghanistan. Since 2011, MSF had provided more than 15,000 surgeries for free to the local people. We had 100 bed capacity, servicing the need of over 1 million people in field. Of course, our GPS coordinates had been completely shared with all parties, and a strict no weapon policy was in place. But what happened was October 3rd, 2015, at around 2 a.m., precise and repeated strikes from a US airplane destroyed our trauma center in Kunduz. The strike killed 42 people, including our 14 MSF staff. And our head of mission made a phone call using hotline to ask them to hold the airstrikes, but it didn't stop for 1 hour. So that was a big tragedy for us. In Yemen, in 2015-16, SF activities came under attack 4 times in the month which followed the destruction of the Kunduz, Afghanistan. So that was also we had lost many staff and patients. In Syria, probably this is the worst context as long as we know in terms of attacks on medical care. I was there for 2 years inside and outside Aleppo. In 2015, only in 1 year, according to our own record, there was over 19 times of attacks, 90 times of attacks on 63 of our 63 of local health facilities supported by MSF. According to some reports, in opposition armed controlled areas, most of the health facilities had been already destroyed. And the significant ratio of attacks are conducted by airstrikes. Considering the accuracy and frequency, although there are several different patterns like collateral damages, mistakes, direct and indiscriminate attacks, but considering the accuracy and frequency, we cannot help assuming that many of these were committed as a part of military tactics. Why it's problem? We are not saying this is a problem because our staff are killed. Apart from the security of medical personnel and patients, the biggest problem of attacks on medical care is tens of thousands of people are deprived of their access to medical care in the area where the need is greatest. As a consequence, countless number of lives that could have been saved were lost in many contexts, especially in Syria. That's why we are saying this is a problem. As Professor Furuya mentioned, this UN Security Council Resolution 2286 was adopted unanimously in May 2016. We were there together with ICRC to make a speech, but it didn't stop. That's why we repeat it, but it didn't stop. It is important to mention here that security resolution, UN Security Council resolution, was proposed by Japan, government of Japan. Government of Japan was one of 5 co-sponsors of that particular resolution. In Japan, MSF Japan, we conducted a big public awareness campaign from 2016 to 17, gathered signatures from over 95,000 people, and we submitted it to the Minister of Health and the Minister of Foreign Affairs, requesting them to use their leverage to work on this issue as government of Japan. That was 2016. However, according to several reports, the situation has not been improved. This is a figure from Safeguarding Healthcare in Conflict Coalition, which will have a presentation from Professor Reuben Stein after me. So as you can see, it's still happening. The situation has not been improved. Why it is happening? What's the behind of this trend? We see as after several analysis, we have some hypotheses. So this is a chart of comparative analysis of attacks against MSF hospitals. As you can see here, we have 3 examples, one from Afghanistan, another from Syria and Yemen. And you can see number of workers present during the attack, number of patients, number of deaths, injured, etc. The point is, okay, GPS coordinates provided to parties. Yes, in both cases, it was down, but the other one, in Syria, it's not, but the place was very well known. And then for identification of the hospital, yes, in Yemen and Afghanistan, Syria, no, but it's very well-known building as a hospital. And military activity, weapon in the hospital, of course, no. It was no in all cases. And then the common points. The context is different, but there was a common point. That was an extreme counter-terrorism context. Yes, in Afghanistan. Yes, in Syria. Yes, in Yemen. Who controls the hospital zone? That also we have a common point. Because in Afghanistan's case, it was in opposition. In Syria's case, it was also in opposition controlled area. And in Yemen, it was also in opposition-controlled area. So from these examples, we can assume that some attacks on medical care are committed in the context of counter-terrorism. So at the beginning of the first session, press session, I said today we have two big topics to tackle, which is attacks on medical care and application of counter-terrorism legislation against humanitarian actors and populations in need. But now I am saying that these two are mixed. Some attacks on medical care in some contexts are committed in the context of counter-terrorism. For instance, in Syria, in opposition-controlled areas, many hospitals were attacked, saying that this is a fight against terrorism. So that's the context. And since when we have this trend, we hypothesize that it started from this moment, 9/11. I mean, the definition of terrorism or terrorists got expanded after this incident. There's no clear agreed definition among states what a terrorist and terrorism is. So each state use each definition to enact a counter-terrorism legislation to use for a political agenda. So I'm saying here is like this. In some states in unstable contexts, starting from meso level to micro level, in some states in unstable contexts, they enact a counter-terrorism law as a domestic law, and it allows military to attack hospitals as a part of military tactics. Now, from the opposite. Now I say, this is the last slide. I go from micro level to meso, macro level. Attacks on medical care, some attacks on medical care are conducted as a part of military tactics. That is happening in some states in unstable context. That's justified by counter-terrorism legislation. And unfortunately, in some Western and European countries, they also use the similar narrative for their national security to enact local domestic counter-terrorism law. That's unfortunately supported by the majority of media and the public, because whenever governments say this is against terrorism, or this is the counter-terrorism, it sounds justified for the majority of media and public, because they don't know the humanitarian consequence on the people, including millions of women and children in conflict situations. So this is the context where we work today. And under the situation, what we can do? Of course, in field level, we need to do the negotiation, direct, bilateral, at off record. We have been doing negotiation with relevant actors at top level to gain security guarantee for hospitals and medical personnel. But because under this situation, it's not enough. I mean, field negotiation is not enough. We need to take a public position, and we need to conduct advocacy, not only in field level, but also in national level, where we are staying in our home society, and also global level. Without this mixed approach in both local and national level and global level, it would be very difficult to tackle this issue for the reason I mentioned. That's all from my side. Thank you very much.
So thank you, Mr. Murata. We could understand very clearly the background of this issue, attacks on medical care. He actually cite very concrete the figures and the numbers of the casualties and something. So we have to bear in mind these data for discussing this matter. Thank you very much, Mr. Murata, once again. So I would like to invite the last and the third speaker, Professor Rubenstein from the United States. So Professor, are you ready? Okay, so I will give you the floor. Thank you.
Hello, everyone. I am truly honored to participate in this discussion. I have long admired and worked with MSF, and I appreciated Sinjiro's presentation and also very much appreciate the work of ICRC. I'm having a little trouble getting my slides shown here. Meanwhile, I'm trying to do that. I don't know why I'm having trouble. I would just like to, actually, maybe if I could ask the administrator to show the slides for me rather than try to do it while I'm speaking. First, I'll tell you a little bit the Safeguarding Health and Conflict Coalition, which has been mentioned already, is a group of about 40 NGOs, including humanitarian organizations, human rights organizations, and professional organizations, as well as academic centers that are devoted to protecting healthcare in conflict. What we do is we document attacks, and you've seen some of our data. We strengthen respect for universal norms. We demand accountability, and we empower providers. The data that you saw was the product of our 7th report on global attacks on violence against healthcare. We've been doing it every year since 2014, and we also engage in global advocacy to protect healthcare in conflict. The coalition began back in 2011 when we advocated for the collection of data by the World Health Organization. Thank you very much for those slides. Why don't we move to the next slide? Next slide. And there's our report from last year. And you're welcome to subscribe to our newsletter. You can contact us at safeguardinghealth.org. Next slide, please. There's a map you'll see of attacks in 2019. It leaves off Myanmar. These are exclusively attacks in conflict areas. We're preparing a report on attacks in connection with COVID. Next slide. What I'd like to do today is talk about a framework for understanding these attacks. That is, what are the logics that are driving these attacks? I think we need to do that in order to develop appropriate responses. And what you see is pictures of profound influence on how we think about protection of healthcare in war. The person on the left you may recognize, Henri Dunant, the founder of the International Committee of the Red Cross, as well as the author an inspirer of the first Geneva Convention in 1864. And his view was that principles of humanity required us to respect every human being, no matter who they are, what their affiliation is, or what they've done. And his goal, as you see, was to prevent or alleviate at least the horrors of war. On the right, I doubt many people will recognize this man. His name was Francis Lieber. He was a Prussian. He fought against Napoleon III. He came to the United States, and during the American Civil War, he developed the first ever code of conduct for a military force, the Union Army. It's still called the Lieber Code. It's cited in military manuals around the world. And he addressed a whole range of issues, including healthcare. He had a different view, though, than Dunant. He believed that humanity was an important value, but it could be superseded by what he called then, and is still referred to, as military necessity. And his concept of necessity was to win a just war quickly. So the protection of people, civilians, and health workers and hospitals depended on whether the war was just and whether necessity required an attack. So you see a quote from the code that hospitals should be protected, but only as much as the contingencies and necessities of the fight will permit. Therefore, he allowed attacks on healthcare in certain circumstances. And the reason I think this is important, and extraordinarily, his code was 1863. So he and Dunant lived at the same time. Their seminal work took place at the same time, and yet they had very different concepts. We embrace Dunant's humanity, but militaries tend to act, notwithstanding the law, which reflects Dunant's views, according to military necessity, even when they don't acknowledge it. And I'd like to explain how I see this framing useful in explaining some of what is happening with respect to attacks on healthcare. Next slide, please. I call them the logics of violence, and I would like to briefly review these 5 logics. One is to deny care to enemies because they are considered not worthy of it or because it provides an advantage. And of course, to punish caregivers who provide it. 2, to target healthcare as a strategy of war. 3, tactical interference with healthcare. 4, really inconvenience. It also can be called recklessness or indifference. That is, it's more difficult to comply, and military forces often would rather not take the time, energy, and commitment to do that. These 4 really relate to concepts of military necessity that derive from Lieber. There's a 5th, which Maciek discussed briefly, which is to send a message of dissatisfaction with healthcare and governance. I'll get to that in a minute. I'd like to review these briefly one by one. Can I have next slide? The concept of denying care to enemies and punishing health workers is something we see all over the world. And there are a lot of rationales or rationalizations for doing that. One is to reduce the military effectiveness of enemies by not having their wounded combatants treated and getting them back into the fight. Sometimes it's used to undermine elites and leaders, which the medical profession is in many countries. It also preserves resources. And in volatile situations short of war, It often can discourage
さらに
protest.、
もう一度その傷ついた兵士たち、あるいはその敵の人たちが、
As Sinjiro mentioned, counterterrorism has adopted this view. The reason health workers are being punished is for the same reason under counterterrorism laws, for the same reason that enemies are denied care and health workers are punished. The Safeguarding Health and Conflict Coalition issued a report on the criminalization of healthcare that reviews the extent to which these denials of care and the theory of denial of care, which is completely contrary to the principle of humanity, has become dominant in the world. Next slide, please. The strategic targeting is most prominent in Syria, where 600 hospitals have been attacked as a strategy of the Assad regime's conduct of the war. And it can be used for multiple purposes. Why would they strategically target health care, or what's the strategy? Well, there are many possible strategies. One is to demonstrate the futility of support for an opponent by collectively punishing the population. It can advance territorial aims by forcing populations to move. It can deplete health services needed to sustain an enemy population. It can be used to control health services, as is done by the Taliban in Afghanistan. It can even be used to advance ideological or political agendas, as attacks on vaccinators usually are an expression of. And it can also disempower elites. So strategic targeting has a rationale in the view of the people who are committing these acts. Next slide. Sometimes a mere tactical advantage is sought by abusing healthcare institutions or ambulances. The picture you see there is the National Hospital in Raqqa, Syria. It was a city ISIS took over, and they used the top of the hospital as a machine gun nest. They also, in Mosul, used hospitals as weapon storage facilities and headquarters for their commands. Ambulances are too often used to transport weapons. It's a way of hiding the weapons behind the emblem, and of course that's prohibited, but it does give a tactical advantage in the minds of the people who do it. Hospitals are also looted of supplies. Well, why is that? Many times it's for financial reasons, but it's also to get medical supplies for fighters. So the combatants see a tactical advantage in violating the law. Next slide. The fourth is what I call inconvenience or recklessness or indifference. It takes work to comply with principles such as proportionality and distinction and precaution. It takes work, it takes training, and it takes time. And Saudi Arabia's bombing of Yemen is a perfect example where there didn't seem to be much of a strategic purpose in bombing hospitals and civilian facilities. But despite efforts by outside groups, nations, states, militaries, the military in Saudi Arabia just would not invest in the effort to comply. Sometimes inconvenience can be a means of limiting risk to one's own forces. And we see that in the Israeli-Palestinian conflict, where hair-trigger shooting at Palestinian ambulances in Gaza and the West Bank has been common during the conflict by Israeli forces in order to reduce the risk, their own forces, no matter that they have other means to accomplish that end. There's a dimension of this we also need to recognize that is indirect, and that is weapons sales that fuel these conflicts. Many countries, including most Western countries for sure, have laws that prevent or prohibit sales of weapons if those weapons will be used in violation of international humanitarian law. But they don't like to conduct the searching reviews required. And for the last 5 years, for example, the United States and the UK have supplied weapons to the Saudis, notwithstanding the fact that the Saudis are engaged in what's likely to be war crimes. So these are 4 dimensions of how Lieber's ideas of military necessity not are justified, but affect the thinking of all too many military forces, both states and armed groups. Next slide. The 5th dimension is a little bit different and was shown in the Ebola epidemic in the DRC. It's a form of expression of anger and a political message to the government. There's a picture of Dr. Muzuko, a physician from Cameroon who came to help the Ebola response along with 1,000 other health workers and support personnel in the DRC. And the violence there was mostly generated because of lack of trust in the government. It had a predatory set of security forces. It failed to provide health care to people. There was no trust. And when groups like MSF were trying to address the outbreak, as well as many other groups, and MSF had been there for 20 years, the anger at the government kind of overwhelmed the trust that people had previously had. And the messages, there were politicians who exploited the lack of trust, and it resulted in more than 300 acts of violence against the Ebola response. Next slide, please. So what do we do about this? How do we alter the logic? I agree with my colleagues, Maciek, who talked about practical measures, Sinjiro, who talked about acceptance strategies. There's a political dimension to this as well. One is at the domestic level, we need leadership to change the laws, to train militaries, to change military doctrine about, for example, searches of hospitals and checkpoint practices with respect to medical transport. And there's also been a shortage of investment in protection by health ministries, which could play a much greater role in this form of domestic reform. There's a second dimension. It's not just domestic. We need much greater bilateral and multilateral inducements to enhance compliance and impose consequences on perpetrators. Some of this involves training and support, but it involves what amount to political decisions. For example, refraining from arms sales to perpetrators, conducting international investigations and accountability. These acts, as we know, take place with impunity, and it's not enough to try to induce compliance. There have to be consequences by prosecutions and other forms of accountability, and they can come through diplomatic action and taking seriously the UN doctrine of responsibility to protect. So you need to do both of these things. Next slide. But there are some challenges, and I'll stop here. I have other slides, but I will just raise three major challenges that we have to face. One is the norms of humanity are at risk. Sinjiro mentioned counterterrorism, and as I mentioned before, the counterterrorism approach to healthcare is based on a very different concept than the principles of humanity, which underlie the Geneva Convention, because that norm of counterterrorism in healthcare is that terrorists do not deserve healthcare. They do not warrant being considered human beings. And until we address that underlying norm and the challenges to it, we'll have very great difficulty countering the logic of denying care to enemies. Second, there has been a complete lack of leadership on prevention and accountability. The resolution that has been mentioned already, 2286, in 2016, has not been implemented. There have been many calls upon member states to take action on the recommendations in the resolution and made by the Secretary General to take preventive measures and to increase accountability, but it hasn't happened. And until it does, we won't be able to make a lot of progress. Finally, there's been complete paralysis at the international level. Since 2286, there has been no prosecution authorized by the Security Council, mostly because of the veto power of Russia with respect to Syria. And there has been a reluctance to take on the issue because of the divisions in the international community. And we have to figure out ways to address this problem in a really serious way at the political level. So I think those are challenges we have to address. And I'll stop there and be happy to continue the discussion as we proceed. Thank you very much.
So thank you, Professor Rubenstein, for your presentation. Now we finished three speakers' presentation. I believe all the participants could understand what we are facing and what we have to do, we have to address at present. So we are moving on to the time for questions and answers between the three speakers and the participant. But before that, using the time for collecting questions from the participant, I would like to ask some questions as a moderator, which I believe would contribute to the purpose of this session and clarify the point the speakers just made in their presentations. My first question is concerning the possible contribution of the government of Japan for this problem. Mr. Murata just mentioned the basic attitude of the Japanese government, and as he clearly mentioned that Japan was very supportive for the Security Council Resolution 2286. But my personal impression is that Japan has taken a little bit reserved attitude to the concrete actions to protect medical personnel at the risk of being attacked in the field. What do you expect the government of Japan to do for improving the current situation of attacks on medical care? So I'd like to ask these questions. First of all, Mr. Polkowski, do you have any idea on this issue?
Thank you, Professor Furuya. Indeed, I do have a couple of ideas. And by the way, thank you to the other presenters for their excellent presentations. I believe the government of Japan could do several things as a promoter and defender of the rule of law and multilateral institutions, as well as a strong supporter of universal health coverage. Japan could play an essential role in ensuring that the Security Council Resolution 2286 is better implemented. in practice, what could it do? I think it could build on its national best practices and investments in the health systems abroad as well. And in this way, contribute to making sure that healthcare workers have the necessary training, skills, and instruments that will allow them to prevent and manage situations of violence. The government of Japan could perhaps also develop concrete campaigns to increase the awareness of the general public at home and abroad. It could, for instance, do so in the frame of the Free and Open Indo-Pacific initiative. I think Japan could also offer its expertise in developing national legislation on protecting healthcare in places where such legislation does not exist, and it could also act as a convener for global or regional fora, where such topics could be discussed. Another idea would be for the government to work with the Japanese self-defense forces and make sure that measures to protect healthcare are integrated in the doctrine and practice. Lastly, there's a particular point here that's linked to the Article 1, common to Geneva Conventions, and I think here Japan could once again play a role, making sure that this article is well understood and implemented by other countries. And just to finish, I think I just wanted to say that I fully agree with Professor Rubenstein and what he said about the rather sorry state of domestic concrete implementations of measures recommended by the Secretary General in his remarks pursuant to Resolution 2286. And I think this has to be said very clearly, that governments that want to project themselves as global leaders on this issue, and this clearly does not apply to Japan only, should really start at home and lead by example, if you will. We've had already a lot of words have been said on this topic. We've had a lot of prominent global governance instruments voted through. What is lacking is really action. Thank you.
So thank you very much. Thank you very much for your comment. Having heard your explanation, and I think the implementation, not just the adoption, the implementation of the resolution 2286 is very, very important. So I would like to ask Professor Rubenstein about the Japanese government role in implementing the resolution 2286. So you just mentioned the domestic implementation is very, very important. Do you think, what do you think the Japanese government should do in implementing the resolution 2286?
Thank you. I agree with everything that Maciek said. The important point is to get one's own house in order. And I'll just give you an analogy, which I think is helpful in showing the way forward. We've heard about the Kunduz attack in 2015. In the wake of that attack, the US Department of Defense committed to review procedures and operational practices and protocols that would protect healthcare in military operations. That was 5 years ago. It never did so. The next year, 2286 was adopted, and it still didn't do anything. So this year, the House of Representatives in the US Congress passed an amendment to our defense bill that said they must do this. And that bill is now pending. It'll be within the next 3 weeks. We'll know whether that's adopted by the entire Congress. And so there is a law, that would be a law requiring the government to do what 2286 asked it to do, that is, review military doctrine, protocol, training to protect healthcare. And I think that's something that other nations, including Japan, can do. If there is resistance, parliament, legislative bodies can get into the act and put pressure on the government, and citizens can demand the same thing so that they do what they've committed to do to prevent these kinds of activities, especially now that Japan is playing a greater role in peacekeeping, and it can be important to make sure these kinds of doctrines and practices are built into military operations. So that's one idea.
So thank you, Professor Rubenstein. So Murata-san, do you have any additional comment on the role of Japanese government to improve the current situation?
Yeah, thank you very much. As two other panelists said, I agree that the government of Japan has a certain role to take, because they are the one of 5 co-sponsors of the UN Security Council resolution. They are also a part of the member of the group of friends of protection of civilians in armed conflicts. They are the one promoting universal health coverage. So yes, there are many reasons for government of Japan to do, but in my opinion, just wishing them to take the leadership, or just hoping them to show their leadership, to exercise leadership in diplomatic arena, is not really. It's not advocacy strategy for us to take. We as one MSF, ICRC, and this Safeguarding Health Coalition, we are the ones who need to raise more awareness among the public in our each home society on this issue. We are the one who witness what's happening in field. We are the one witnessing humanitarian consequence on civilians, including women and children. And the government of Japan, as many other governments, they have lots of other political agendas, economy and other, like their national security. They are busy basically. Why do they need to care about it? Then the only way to make the government of Japan take it seriously is probably to raise awareness among the public first, and the media, and using the media and gaining support from the public to put the pressure on the government to work on it. Without this process, without this grassroots efforts, without making these grassroots efforts, I think it's very difficult to advocate the government of Japan to do more, because that's not in their list. So there's a role. I mean, before thinking about the role of government of Japan, I think we have a role to take as a humanitarian organization and as an academic party to talk about this topic more occasionally whenever we have the opportunity to raise awareness and to gain support from the public and media. So that's my point.
So thank you very much indeed. I fully agree with your opinion. If we need the grassroots movement toward the improving the current situation, we need the much more participant participation of the peoples in this movement and this campaign. So in this respect, I think the participant today's participants to today's session is a very important persons who would be a candidate for our new members or a new movement. So if you have any particular message to the participant, would you please give them your comment or your opinions? So, Mr. Polkowski, do you have any specific message to the audience?
Thank you. I think many of us participating here today are aid workers, and many of those aid workers are also health workers. I think, especially if you're looking at the movement such as the MSF, obviously provision of healthcare is the key area in which you are active, and I think from that perspective, it's important to stress the active role that healthcare workers themselves play in building their acceptance and advocating for their rights, but also fulfilling their responsibilities. And I think Mr. Murata spoke about it very well during his presentation. I always stress that healthcare workers should not be seen as just passive victims in this whole conundrum, but that we should recognize the active role they have to play in fostering their own protection, but also in preventing violations to the medical ethics, for example, that undermine the respect not only for their own healthcare operation or establishment, but also ultimately for the entire medical profession. And I think, therefore, wherever humanitarian health activities are carried out in support of local structures, this kind of work, the work for protection of the medical mission, should be built into that as well. We shouldn't only train local health workers on infection prevention and control, but we should also speak to them about security of facilities, about coordination with law enforcement and military actors. We should speak to them about medical ethics. I think these are all very important issues. I think maybe I'll just stop here and let other panelists provide their views as well.
So thank you. So Murata-san, do you have any message to the participant?
Well, thank you very much. In Japan, I know that because I'm from Japan, that in Japan there's a serious lack of interest in this kind of topic among the media and the public, unless a humanitarian aid worker from Japan gets involved in an attack and killed. In that case, it appears on the media, TV news, etc. But if nothing happens, even when many civilians, women, children are killed in Syria, Yemen, Afghanistan, etc., because of attacks on medical care, basically there's no interest. So we are in a bit difficult context, to be honest, to raise awareness. But that's one of the reasons why today MSF Japan we are holding this humanitarian congress by inviting you from academic academic area and also from other organizations to be together to raise awareness, at least for today's participants. We have around 100 people. They are also like university students and researchers, professors, and aid workers, etc. So without having these like step-by-step approach, it's
いろんな方たちに対してステップバイステップで少しずつでもいいんです。
At least for today's participants, I hope they everyone got an idea what attacks on medical care means, which kind of causes are behind, and then okay, what we can do here in our home society, Japan. That's what we need to think about it. And MSF Japan, we're willing to have that discussion with ICRC in Japan or other academic parties in Japan, or even with other like any other parties. We are willing to engage to talk about it. So that's what probably we need to do as MSF Japan, but also that's what we expect today's audience to remember from today's session.
So thank you very much, Murata-san. Today we have more than 100 participants, and most of them are involved in the medical or humanitarian aid activities. But the audience also includes so many young students who are very interested in this issue, and probably they are interested in their future career as participating in this kind of the medical and the humanitarian aid. So, Professor Rubenstein, do you have any message to the particularly younger participant audience in relation to this issue?
Well, I find it very gratifying to hear the interest. I would encourage all the students and young people who are interested in this to get involved. There's a huge need. We know that the number of wars in the world is enormous. We know that there's a huge need to address the refugees and displaced people and provide them the kind of assistance that they're entitled to, and to do so in a safe way. So all I can do is encourage you to get involved and to pursue opportunities, whether it's with MSF or ICRC or Save the Children or any other organization, to look at opportunities to prepare, get trained, and go into the field. I also think there's a huge role for students and young people in overcoming the resistance and the indifference to protection issues. We just heard that it's very difficult to get traction on protection issues. And I think some organizing and speaking out it goes hand in hand with the kind of commitment that so many of you have.
Thank you very much indeed. Now we have several questions in the chat box. So I'd like to introduce these, and I'm looking forward to your answers to this question. The first question I received is like this. I feel that the current campaign of attacks on medical care by MSF, ICRC, and WHO are not effective as they are carried out separately by each organization. Are there any plans for multiple organizations to come together to organize one big joint campaign? So this is a very, very important point, I think. So, Mr. Polkowski, do you have any idea, or you have actual plan or actual action, joint action with other international organizations or national organizations?
Mm-hmm. Well, thank you so much. I think it's an interesting question, and I would perhaps submit that we have not been that uncoordinated all these last few years. I'm not going to pretend that we have been as effective as we would have liked to be, because that is clearly not the case. I think the challenges are in front of everybody's eyes, and all of us, the speakers on this panel, repeatedly stated that that these violations continue, or perhaps even on an increase these days. So I'm very far from, and I think we should be very far from congratulating ourselves, and it's definitely not what we've been doing. At the same time, as I said, there has been coordination between our organizations and with the MSF, with the Safeguarding Health in Conflict Coalition, with the World Health Organization, International Federation of Medical Students Associations, International Hospital Federation, World Medical Association, and so on and so forth. We have been working in close coordination on this topic during the past years. Now, in terms of whether we need a campaign on this, that is an interesting question as well, and I think the answer to a large extent depends also what exactly we mean by a campaign. Next year we'll see the 5th anniversary of the resolution 2286. I understand that on this occasion there will be a debate in the Security Council and around it during the Protection of Civilians week, and but a lot of this debate will specifically next year focus on protection of the medical mission. I think this will be a good opportunity to for all of us to raise our voices and say very strongly what our assessment is of the current state of implementation and what further concrete steps are needed. And while I do agree with the need to also mobilize the public, I think there's also space for silent humanitarian diplomacy and lobbying. I think we should be realistic when it comes to how much support we can really garner for this issue in the general public. While this is obviously an extremely serious humanitarian issue that affects the lives of millions of people around the world, I find it difficult to imagine that suddenly protection of the medical mission becomes a #1 topic for the media around the world. We should be a bit more realistic about this, and therefore more targeted in our mobilization efforts. And I think here it's probably groups that already have an interest in related issues, such as professional medical associations, other health bodies, that should be thinking about coming together and lobbying their governments with very concrete proposals of what needs to happen. Because as my co-panelists pointed out, the governments are also extremely busy. They have multiple things on their agenda. And if we just say that something needs to happen and then leave it to them to conceptualize what it is that they have to do, that will hinder progress. We should be very concrete in presenting good practices, in presenting concrete legal and health systems solutions and present them to governments for them to approve and implement. This is how I would see it.
So thank you very much indeed. So Murata-san, do you have any joint action, a joint plan in Japan for this movement or campaign?
As of today, we don't have any plan to do big public awareness campaign on this topic, even as MSF Japan alone. What we are going to do is to take several existing opportunities and strong supporters of MSF to raise awareness of this topic first among them, and then going to some selective, key audiences. Then when we go to talk with key audiences like medical communities, associations, and students, etc., it would be effective to do it together with the other organizations like ICRC in Japan and others. So I do agree that doing any kind of advocacy, grassroots also, and also to the top level also, doing it alone is not effective. So we need to find a way to do it together. And but I'm very happy to have such a conversation with other organizations to make a plan to do it here in Japan.
So thank you. So Professor Rubenstein, you were the founding father of NGO Safeguarding Health in Conflict Coalition. So what's your idea, what was your idea to establish this coalition? Do you have any idea on the cooperative relations with other NGOs or other movement for improving the current situation of the conflict?
Thank you. And I want to endorse first what the other panelists said. And I think that we have to recognize when we talk about joint actions that we can cooperate. For example, the coalition is a member of the healthcare endangered community of concern. So we cooperate. But we also have to recognize that different organizations have different missions. And so there's a place for different kinds of organizations that can act in ways that others might not. For example, the ICRC has great access and confidential relationships with state militaries and governments, but they are, because of those relationships and because of the humanitarian mission, they really don't get too much involved in issues around accountability. We started the coalition in part to fill that gap, to be able to advocate on the global and domestic level, at the political level, to press for methods of ending impunity as well as for prevention measures. So we have to respect that. There are other opportunities. For example, there is a movement, a civil society movement to protect civilians in conflict because the number of civilian casualties is so high. And they're not particularly focused on health workers and the wounded and sick, but civilians generally. But there's more and more communication with those groups so we can support each other. So that's very important. I think the one thing that is missing is the health community could be more, acting more in solidarity. International health organizations like the World Medical Association, the International Council of Nurses are outspoken, but there's been much less solidarity at the national level. And I think in COVID, we've seen that medical groups have spoken up much more vociferously about protecting their colleagues who are being assaulted during the COVID pandemic. And I think we have to extend that more broadly so that doctors, nurses, other health workers think of their mission and their purpose to embrace protection of their colleagues, so that they raise their voices in all kinds of circumstances, the national level, as well as through their international organizations. So I think on the one hand, there's been a lot of cooperation and respect for different missions of organizations, but we could do a lot more.
So thank you very much indeed. So for the interest of time, I would like to move on to the next question. So next question is a little bit long one. I read it. Many advocates emphasize the fact that attacks on healthcare facilities are violations of IHL, International Humanitarian Law. However, many of these attacks are occurring in opposition-held area by informal armed actors and or is strategically conducted. These facts makes it evident that there is very little respect for IHL. What do you think are ways forward in advocacy beyond advocating for respect for IHL? But I think this is a very difficult question, but a little bit legal one. So I would like to ask Mr. Polowski. So what is the attitude or ICRC for provoking or encouraging the non-state actors for respecting the IHL?
This is indeed a rather broad and almost intimidating question. I have to admit, but at the same time, it's obviously at the heart of what we're talking about here, and I think Professor Rubenstein's presentation was helpful in outlining the different logics or motivations behind such attacks, and this is important because different logics will obviously determine different prevention and protection strategies that should always address the root causes. When it comes to different armed actors, including non-state armed actors, we have been taking these various logics into account. And in fact, a few years ago, as you may know, we released a dedicated publication on protection of healthcare and non-state armed groups.
ということで、このノンステートアームグループ、こういった政府勢力に対する
The various typical reasons why such actors attacked healthcare, and then proposes concrete solutions that are applicable to such scenarios. But then obviously when it comes to working with armed groups, there's a range of other aspects that have to be taken into consideration that go beyond the thematic of protection of healthcare in and of itself. There's issues of access to those individuals, security concerns, cultural and religious considerations, and so on and so forth. So it's a highly complex topic. And I'd like to mention here, I know the question was focused on non-state actors, but when it comes to state actors, we have just completed a major exercise of analyzing the military doctrine and practice based on a sample of 20-odd militaries, national militaries, and international organizations with a military component. And we've unfortunately concluded that this consideration is not well integrated at all, despite all the international attention it has received. And following this finding, we are now about to release a very comprehensive guidance document that will hopefully allow militaries, but also the more structured non-state armed actors around the world to look at their practice from the perspective of multiple scenarios and multiple operational domains, and to see how concretely they can advance the cause of protection of healthcare by integrating training mechanisms, standard operating procedures, rules of engagement, targeting procedures, and so on and so forth.
So thank you very much. In relation to what you just mentioned, I have a third question, very closed one. So third question is like this. When conducting advocacy toward organized parties, such as nation states and anti-government forces, there is a clear target to which advocacy can be tailored. However, attacks on medical care are often carried out by informal gangs, not even organized as terrorists. Do you conduct advocacy towards these parties? And if yes, how? So I think this question is very, very legalistic, but at the same time, very practical
関わっ
matters.
てくるかと思うんですけれども、しかしかなり戦術的な質問でもあるかと思いますので、村田さんの方からご経験があるかどうか伺いたいと思います。
Association with the local peoples who is in a sense are not so familiar with the international humanitarian law, and sometimes they violate the rules. So do you have any experience to have such a consultation and the corporate activities to respect IHL?
Thank you very much for this very practical and also good question. So when we are talking about like non-organized groups in field, in my experience, the most important point is like how we can reach them to explain who we are, why we are here, and what we want to do. So it's very close to what I explained in the first part of my presentation. It's a kind of acceptance strategy. Without having a communication, it's impossible to gain acceptance. So first, it's important to reach them. But if in case it's very like a disorganized group, which we don't know who, with whom we can talk, etc. Then what we can do is, I mean, to establish a network, peripheral. I mean, not directly with them, but with other actors, other parties, other communities who knows about this kind of group. So gaining understanding and support toward our medical actions from these actors first, we may be able to gain, I mean, reach this kind of people, or they are the one who can spread our good image, reputation toward the other people. That can reduce the risk for organization like us to face. There's no particular way to do it. It really depends on context and the context. And it's difficult to talk about IHL for this kind of people, but it's more like, okay, in case we reach them, we need to I mean, to help them understand like the medical humanitarian needs among their populations. They also have families, they also have friends, they also have the relatives, etc. So if we manage to explain very well, in some cases we can reduce the risk, and that's how we work in many contexts. Of course, it's not perfect, but that's how we work.
So thank you very much, Professor Rubenstein. Do you have any comment on how to oblige non-state actors, less organized groups to comply with international humanitarian law and avoid the attacks on medical facilities and the personnel?
Thank you. First, I'd like to say that both MSF and ICRC do a remarkable job in negotiating security with armed groups. This is all takes place behind closed doors. It's not very public, but they both make huge efforts and are quite often successful in negotiating with organized and sometimes unorganized armed groups, working with communities and leaders in the community to restrain the unorganized groups whenever they can. And we don't really know how many attacks have been prevented by that strategy, but I'm sure there are many. I want to make one other point about armed groups. There's a kind of a myth out there that armed groups are not as susceptible to admonitions to obey the law as state actors. I'm not even sure that's the case. We have a lot of evidence, actually, that because armed groups often have particular interests, for example, in taking over governance of a country, they are concerned about legitimacy, they are concerned about their image, and can be influenced. And just to give you an example, in Afghanistan, the Taliban, which is hardly a perfectly behaved group, is very sensitive to criticism by UN human rights monitors. And they always try to push back about how concerned they are and to obey abide by their obligations. They don't always do that, and they have rather strange interpretations of what their obligations are. They tend to reject principles of distinction and proportionality. But they are influenced, and you can actually trace the history of their violence against healthcare. So we have to recognize that, as Sinjiro said, context is everything, but there are ways of influencing, not simply by appealing to humanitarian law, but by figuring out what their interests are and what pressures can be brought upon them. It's much harder with the unorganized groups, of course, but it's a matter of just developing a strategy in the right context, a right strategy in the context. Thank you.
So thank you very much indeed. So I'm afraid time to close this session is approaching, and we have 5 minutes left. So if you have any particular final message to the participant, would you please give that? But I can give you only 1 minute for each. So Mr. Polkowski, do you have any message to the audience?
First of all, I would like to thank the organizers of this panel and my co-panelists for this excellent discussion and an exchange of ideas. I, for one, definitely benefited from some of the remarks that were made, and I'm taking away some fresh ideas from this, and I hope that the audience can say the same, at least to an extent. And I thank you very much for your patience and for your commitment and interest in what is a hugely important yet poorly understood humanitarian issue. Thank you. Thank you for this interest.
Thank you very much. So, Professor Rubenstein, do you have a final message or very important message to the audience?
Yes, just one thing. Of course, I really appreciate the opportunity to participate in this important discussion. Just a comment about a couple of questions that have come up in the chat about the culture of impunity. It's true there is a culture of impunity. I think what we have to realize that human rights are always subject to that kind of culture, and it's always a struggle to hold people accountable and to make sure that there are consequences for these kinds of violations. It's never going to be easy. There's no simple answer. We just have to keep at it. We have to keep speaking up. We have to keep shaming perpetrators. We have to keep demanding that other institutions take aggressive action to hold people to account. That's our job. And I would welcome the opportunity to work with all of you toward that goal.
So thank you very much indeed. So Murata-san, the MSF Japan is a host of this Humanitarian Congress Tokyo. So do you have any message to the audience? And you also have the other two sessions tomorrow. So you can conclude this session by your message to the audience.
Thank you very much, Professor Furuya, and thank you very much for the other panelists. I really appreciate that everyone was here until 9:30. As I said, there's no perfect solutions on this topic, and also it's impossible to change the situation in a short period. If we could have done that, we could have done that it's more long time ago. But the situation is so complex, and that's why we are having this situation even today. And I hope this time was a good opportunity for everyone to know the trend and to know what's behind. And also, I want to continue having a discussion with today's panelists and today's audience to discuss what we can do more here in Japan to raise awareness and also to put the pressure on the government of Japan in the end. So thank you very much for everyone. Tomorrow we have the second day of Humanitarian Congress Tokyo that we will talk about the COVID-19 and also we talk about one particular context, which is Yemen. We have also very good panelists. So if you have time, please join us tomorrow also. Thank you very much for today's your patience and participation. Thank you very much.
Thank you, Murata-san. I'm afraid we come to the time to end. In concluding this session, I would like to thank, first of all, three distinguished speakers. Thank you very much. And my thanks also extend to all the participants who are actively involved in this session, even this is online meeting. And last, but certainly not least, I express my thanks to the staff of MSF for supporting this session. Now, this ends the session. Once again, thank you very much indeed. Have a good day. Goodbye.
Thank you.
Thank you very much.